So, Chapter 13, Vascular Access and Medication Administration. Your national standard competencies for pharmacology applies to patient assessment management, fundamental knowledge of the medications carried by advanced emergency medical technicians that may be administered to a patient during an emergency. We're going over medication administration. That's going to be routes of administration, self-administered medication, peer-administered medication, and how to assist and administer medications to a patient. We'll talk a little more about the names, the effects, indications, routes of administration, dosages for the medications administered. Some of that we did go over in Chapter 12, so it'll be a little bit of a review. The actions, contraindications, complications, side effects, and interactions. All right. Before you administer medication to a patient, you must have an understanding of how the medication will affect the body. This is also true of medications belonging to the patient that you may assist the patient in taking. This includes familiarity, I can't talk tonight, y'all, with the medication's mechanism of action, indications, contraindications, routes of administration, dose, adverse reactions, and what to do in the event of an adverse reaction. The first rule of medicine is first do no harm. Ensure that a particular medication is clearly indicated to treat the patient's condition. A careful assessment of the patient will help ensure that only beneficial medications are administered. In intravenous or IV therapy, this is one of the most invasive procedures an advanced EMT learns. Few procedures will require more training or practice. Proficiency in IV therapy and technique is required for most procedures administered in advanced life support. A medical problem of any type alters the established balance among the systems of the body. Homeostasis produces optimal physical performance. Healthcare provider must fully assess a patient's condition and identify and treat life-threatening injuries and illnesses that alter homeostasis. You must also have an understanding of basic math for pharmacology to calculate the appropriate medication dose. That's the fun stuff, y'all. Drug doses and flow rate calculations are common areas of confusion for many pre-hospital personnel. These are skills you will need to perform frequently in the field. As an advanced EMT, you must learn to quickly and accurately calculate doses to maximize the chance for a positive patient outcome. Disastrous results, including death, may occur if you administer an inappropriate drug or dose, give a medication by the wrong route, or give the medication too rapidly or too slowly. That's some pretty scary stuff. Medication administration, medical direction. Medication administration is governed by your local protocols and online medical direction. The medical director for your service may allow the administration of certain medications if the patient meets certain criteria. Most EMS services carry drug boxes with a variety of cardiac medications, pain medications, anticonvulsants, antiemetics. What's that for?
I don't know.
Okay, antiemetics. Emetics is emesis, that's vomiting. So an antiemetic would be Zofran, Benadryl in severe cases. So to keep you from vomiting. Other medication.
Important.
Do what?
I said them's are important.
They are important. It keeps our boots clean. Other medications specific to their service. All right, standing orders are a form of offline or indirect medical control. Where do we get those? Protocols, very good. An advanced EMT performs certain predefined procedures before contacting the physician. Some EMS system medical directors require advanced EMTs to contact them before performing certain procedures. Those are the category Bs in your protocols. And then you go by online direct medical control for those. Local policies and procedures are designed to guide you in a specific situation. An advanced EMT's responsibility associated with drug orders. The danger of something going wrong when administering a medication can be minimized by confirming the 10 rights of medication administration. That's going to be the right patient, right medication, right dose, right route, right time, right documentation and reporting, right assessment, the right to refuse, right evaluation, and right patient education. It's a lot of rights. The procedure for administering any medication is as follows. Obtain an order from medical control. This may be given directly through online medical control via telephone or radio, or may be indirect through protocols that contain standing orders for administration of certain medications. When you are communicating with medical control about administering a particular medication, make sure that the medication is indicated for the patient's condition. Knowledge of each medication that you carry on your ambulance is critical to safe patient care. You need to know the indications, contraindications, therapeutic effects, side effects, and appropriate doses. Know when and when not to administer a medication. Make sure medical control understands the situation. The decision to order administration of any medication is complex and should involve consideration of the patient's age, weight, clinical status, allergy history, concomitant medical problems, other drugs he or she may be taking. It is critical that you obtain and communicate complete, accurate information about the patient to the physician. Verify that your patient is the right patient in situations where there are multiple patients. If you are assisting a patient with his or her medication, be sure it is prescribed to that patient. Make sure you understand the physician's orders. Repeat any orders word for word for verification. Inquire about any medication allergies the patient may have. Verify the proper medication and prescription. Note the concentration printed on the label. Read the drug label at least 3 times before administration to ensure you have the right drug. When it is still in the drug box it came in, when you prepare the drug for administration, and before actually administering the medication to the patient. Verify the form, dose, and route of the medication. Check the expiration date and condition of the medication. What does that mean, the condition of it?
If there's like something wrong with the packaging, like you're supposed to check normal saline for any floaters or anything like that.
Absolutely. Check it to make sure it's not discolored. Make sure that it's not got things floating in it, that kind of stuff. Confirm medication compatibility. Should any cloudiness occur after a medication has been injected into the IV tubing, clamp the tubing immediately and replace it with a new administration set. Dispose of any syringes and needles safely. Monitor the patient for possible adverse side effects and always document your actions and the patient's response on the patient care report after administering a medication. You need to make sure you document the name of the medication, the dose you gave, the time you administered it, the route of administration, your name or the name of the person who administered the medication, and the patient's response to the medication, whether it was positive or negative. Specific medications. As an advanced EMT, you may administer the following: oxygen, oral glucose, glucagon, 50% dextrose or D50W, IV fluids, D5W, that's 5% dextrose, normal saline, lactated ringer solution, epinephrine, MDI medications, those are metered dose inhalers, and that's albuterol. Nebulized medications, also albuterol. Nitroglycerin, that can be spray, tablet, or paste form. Nitrous oxide, naloxone, aspirin, and others based on local protocols. Recall that you may only administer or help administer these medications when allowed by local protocol or ordered by a licensed physician. Basic cell physiology. This provides an understanding of how administering fluids to a patient can be beneficial. A human cell can exist only in a special, balanced environment. Because cells are completely enclosed by a cell membrane, compounds must move through the membrane to enter a cell. The composition of the cell membrane allows it to have selective permeability. The cell membrane is a phospholipid bilayer, which is an important barrier to fluid movement and the acid-base balance. Electrolytes. Atoms carry charges, positive or negative. Two or more atoms bond together to form a molecule. Molecules containing carbon atoms are organic molecules, and molecules created without carbon are called inorganic molecules. Inorganic molecules give rise to electrolytes when they dissociate in water into their charged components. Electrolytes, or ions, are reactive and dangerous if left to circulate in the body. Water in the body helps to stabilize the electrolyte charges so that electrolytes can be used to perform the metabolic functions that are necessary to life. A cation is an electrolyte with an overall positive charge. An anion is an electrolyte with an overall negative charge. Sodium is the principal extracellular cation needed to regulate the distribution of water throughout the body in the intravascular and interstitial fluid compartments. It's a major factor in inadequate cellular perfusion. Sodium is also a major component of the circulating buffer. Sodium and potassium, or Na and K, both of those are positive. Pump is helped by the presence of insulin and epinephrine. Hypokalemia, which is low potassium, can result in decreased skeletal muscle function or GI disturbances and alterations in cardiac function. Hyperkalemia, which is high potassium, can result in hyperstimulation of neural cell transmission, resulting in cardiac arrest. Calcium, or Ca positive, is a principal cation needed for bone growth and plays an important part in the functioning of heart muscle, nerves, and cell membranes, also in blood clotting. Hypocalcemia, low calcium, can result in overstimulation of nerve cells that results in skeletal muscle cramps, abdominal cramps, carpopedal spasms, those are the hand and the feet, hypotension, and vasoconstriction. Hypercalcemia is high calcium, and that can result in decreased stimulation of nerve cells, which also results in skeletal muscle weakness, lethargy, ataxia, vasodilation, or hot flushed skin. Bicarbonate levels are related to the conditions of acidosis and alkalosis in the body. Chloride primarily regulates the pH of the stomach, and phosphorus is an important component in the formation of adenosine triphosphate, or ATP. Body fluid composition. Fluids found in the body are composed of dissolved elements and water. A solution is a mixture of two things: the solvent, which is fluid that does the dissolving, and the solute, which is dissolved particles contained in the solvent. Fluid and electrolyte movement. Water and electrolytes move among the body's fluid compartments according to some basic chemical and biologic rules. Balance across the cell membrane has two components: balance of components on either side of the cell membrane and balance of charges on either side of the cell membrane. Materials flow from an area of higher concentration to one of lower concentration, establishing a concentration gradient. The process of flowing down a gradient depends on whether the cell membrane will allow the material to pass through it. What is that? If it decides if it's going to allow something to pass through it. Exactly, semi-permeable. So it's selective, it allows some stuff to pass and then others it does not. Y'all remember this stuff? Diffusion. Compounds or charges concentrated on one side of a cell membrane will move across it to an area of lower concentration. I'm pressing buttons. Filtration is a type of diffusion used by kidneys to clean the blood. Water carries dissolved compounds across the cell membranes of the tubules of the kidney where the dissolved compounds are trapped. Active transport. This is the method used to move compounds to create or maintain an imbalance of charges. Example is the sodium-potassium pump. The cell uses sodium outside of the cell and potassium inside the cell for depolarization. The cell uses energy in the form of ATP and actively transport the compounds across its membrane. Osmosis is the movement of water across a cell membrane. It occurs when there are different concentrations on each side of a membrane. Increasing the concentration of sodium in the extracellular fluid decreases the water in the fluid. Water moves out of the cell to create a balance of water molecules and to dilute the increased concentrations of sodium. Osmotic pressure is increased yet balanced, and the volume puts pressure against the cell wall. The tonicity of the solution, the effects of osmotic pressure on a cell. An isotonic solution has the same concentration of sodium as does the cell. A hypertonic solution has a greater concentration of sodium than does the cell, and a hypotonic solution has a lower concentration of sodium than does the cell. All right. The tonicity of the solution, the effects of osmotic pressure on a cell. An isotonic solution has the same, we just did all that. So it's telling us again on this slide, so it must be important because they're saying it twice. So isotonic solution has the same concentration of sodium as does the cell. Hypertonic has a greater concentration of sodium, and hypotonic has a lower concentration of sodium. Who can tell me, y'all remember that same illustration from previous chapter where the cell burst? Y'all remember what that's called?
Process.
Very good. That makes me proud. Okay, fluid compartments. Fluid storage locations are defined by their relationship to cells. Water can be intracellular, which is inside the cell, or everybody say hello to DJ. Extracellular, outside the cell. Water levels in these compartments constantly shift, but homeostatic control mechanisms ensure balance is restored. The body's circulatory or vascular system functions as a fluid highway and contains cells. It can be thought of as another fluid compartment. Extracellular compartment is broken down into two sub-areas: the intravascular, which is the water portion of the circulatory system surrounding the blood cells, and interstitial, which is the water outside the vascular system and between the surrounding cells. that acts as a buffer between the other compartments. There are 3 fluid compartments in the human body. Intravascular is extracellular, interstitial is extracellular, and then you have the intracellular. Extracellular fluid, or ECF, occupies any area that is not inside the cells. ECF compartments act as conduits for transferring gases and nutrients between vascular and interstitial fluid compartments. ECF is found in the interstitial and intravascular compartments, and the levels are regulated by the presence of sodium. Interstitial fluid accounts for 16% of total body weight. That's a lot, y'all. That's a good bit. It occupies the microscopic spaces between cells. It consists of a gel-type protein that helps disperse the water evenly throughout the interstitial compartment. This helps move water freely between cells and vasculature. Okay,
So my camera, I'll turn my camera on in just a few minutes. I'm doing a few things, and then when I sit down, I'll turn it on.
You're fine. I can't see you anyway. I'm sharing my slide. Okay, perfusion occurs in the capillaries as a result of high hydrostatic pressures and osmosis in the capillary beds. Intracellular fluid, or ICF, is within all cells of the body. Large proteins within the cell can draw fluid into the cell. And there's your little picture showing you where, if y'all can see that, I might need to blow it up. And remember that you can also zoom in on the slides on your end too. It shows you where the interstitial and intracellular and intravascular fluids are located. Now I got to figure out how to fix that. Okay, fluid balance. Some form of water surrounds all cells. Cells survive as long as this environment remains stable. The role of water in the body is diverse. It plays a part in cellular metabolism and maintenance of homeostasis. The body adjusts to changes in the balance between the ICF and ECF by retaining or eliminating water. Fluid levels in the body are balanced when intakes equal outputs. The maintenance of the internal environment of the cell is regulated by elaborate systems of checks and balances. As systems in the body become imbalanced and begin to shift, feedback systems create an appropriate response to return the internal environment to normal. Normal balanced condition is referred to as homeostasis or resistance to change. When disturbances in homeostasis occur, certain conditions develop. Dehydration is the depletion of the body's total systemic fluid volume. It's more common in older adults and young children. It may take days to manifest, and it could be the result of a medical condition. As fluid is lost from the vascular compartment, the body reacts by shifting interstitial fluid into the vascular area. This forces a shift of fluid from the intracellular to the extracellular compartments, and total systemic fluid deficit occurs. Signs and symptoms of this include decreased LOC, orthostatic hypotension. What's orthostatic mean? Does anybody know?
So ortho means straight, right?
So when you have change in positions, so if you go from laying down to sitting up and sitting up to standing up, those are orthostatic changes. So people that are dehydrated will experience a blood pressure drop when they change positions from laying to sitting to standing.
Okay.
Does that make sense? I know that most of you have ran a patient that says when they stood up, they got really dizzy or they felt like they were going to pass out.
Yeah, no, I just never knew what it was called.
Yes, that is why. So as they make those changes in position, the blood pressure will drop. So other signs and symptoms are dry mucous membranes, tachycardia, coarse skin turgor. What is the turgor?
I was saying, think that when you pinch the top of the hand.
Yes, when you pinch the skin and see how long it takes it to go back down. So if it's really dry, it's going to have poor turgor. It's going to stay kind of tinted up. Flushed dry skin and decreased urine output. Causes include diarrhea, vomiting, GI drainage, hemorrhage, insufficient fluid or food intake, and infection. Overhydration. This is the result of a total systemic fluid volume increase in the body. Fluid fills the vascular compartment, filters into the interstitial compartment, and is forced from the engorged interstitial compartment into the intracellular compartment. Fluid backup can result in death. Signs and symptoms include shortness of breath, puffy eyelids, edema, polyuria, moist crackles or rales, and acute weight gain. Causes include unmonitored IV lines, kidney failure, and prolonged hypoventilation. IV fluid composition. IV solutions are tools designed to facilitate patient treatment. The use of IV fluids can significantly alter the patient's condition. Compounds and ions dissolved in the solution are identical to the ones found in the body. Each solution is a concentration of solute and solvent. Sodium is used as a benchmark to calculate a solution's tonicity. Concentration of sodium in the cells of the body is approximately 0.9%. A common IV fluid that advanced EMTs administer is normal saline. Altering the concentration of sodium in the IV solution can move the water into or out of any fluid compartment in the body. Types of IV solutions. IV solutions are categorized as crystalloid or colloid based on their dissolved components or makeup. Crystalloid solutions dissolve crystals in water. It contains compounds that quickly dissociate in a solution. The best choice for pre-hospital care of injured patients with body fluid loss. 3 milliliters of isotonic crystalloid solution is needed to replace 1 milliliter of patient blood. It does not have the capability of carrying oxygen. A bolus is a single dose given via the IV route. Boluses of 20 milliliters per kilogram should be given to maintain perfusion, which is, you know that they're perfusing if they have a good radial pulse, but not to raise the blood pressure. Increasing blood pressure with IV solutions, it dilutes the remaining blood volume and may increase internal bleeding by interfering with hemostasis. Colloid solutions contain molecules, usually proteins, too large to pass out of the capillary membranes that remain in the vascular compartments. And they have a very high osmolarity, and they draw fluid from the interstitial and intracellular compartments into the vascular compartments. They work well in reducing edema while expanding the vascular compartments. They could cause dramatic fluid shifts and place the patient in considerable danger if they are not administered in a controlled setting. Isotonic solutions. There are 3 categories related to tonicity. They are isotonic, hypotonic, and hypertonic. Isotonic solutions such as normal saline possess nearly the same osmolarity as serum and other body fluids. Osmolarity indicates how easily or not water will move. Isotonic solutions expand the contents of the intravascular compartment without shifting fluid to or from other compartments. The fluid remains in the vascular compartment, so be careful to avoid fluid overloading. Patients with hypertension and heart failure are at greatest risk of fluid overload. Lactated Ringer solution is generally used in the field for patients who have lost large amounts of blood. D5W is a special type of isotonic solution. As long as it remains in the bag, it is considered an isotonic solution. After administration, the dextrose is quickly metabolized and the solution becomes hypotonic. Hypotonic solutions. Hypotonic fluid has a lower concentration of sodium than the cell. It hydrates the cells while depleting the vascular compartment. It may be needed for a patient on dialysis when diuretic therapy dehydrates the cells. It's dangerous to use because they can cause a sudden fluid shift from the intravascular space to the cells. It's dangerous to use on patients experiencing a stroke or head trauma, or patients with burns, trauma, malnutrition, or liver disease. Hypertonic solutions has an osmolarity higher than serum. It has more ionic concentration than serum. Hypertonic solutions shift body fluids into the vascular space and pull fluid and electrolytes from the intracellular and interstitial compartments into the intravascular compartment. They help stabilize blood pressure, increase urine output, and reduce edema. They are rarely used in the pre-hospital setting. It often refers to solutions that contain high concentrations of proteins. Careful monitoring is needed to guard against fluid overloading, and it should not be given to patients with diabetic ketoacidosis or others at risk of cellular dehydration. Techniques and administration. Keep the IV equipment sterile. Develop a routine to follow as you assemble the appropriate equipment. Assembling your equipment. Prepare all equipment before you attempt to start an IV line. Your equipment includes elastic constricting band or tourniquet, antiseptic wipe or solution, gauze, tape or adhesive bandage, appropriate size IV catheter, IV extension set, a saline flush, and IV administration set. Table 13.1 in your book shows a logical sequence of steps in assembling your equipment and performing IV therapy. Choosing an IV solution. Identify the solution and needs of the patient. Ask yourself, is the patient's condition critical? Is the patient's condition stable? Does the patient need fluid replacement? Each IV solution bag is wrapped in a protective sterile plastic bag. The bottom of each IV bag has an access port for connecting the administration set. A removable pigtail that represents a point of no return line protects the sterile access port. The IV solution bags come in different fluid volumes. Choosing an administration set. Administration sets move fluid from the IV bag into the patient's vascular system. Each IV administration set has a piercing spike protected by a plastic cover. There are different sizes for different situations and patients. Most drip sets have a number visible on the package. This indicates the number of drops it takes for 1 milliliter of fluid to pass through the orifice and into the drip chamber. Okay, does that make sense to you? Like on the truck, we carry 10 drop sets and 60 drop sets. So what those numbers represent are, on a 10 drop set, it takes 10 drops of fluid to equal 1 milliliter. The 60 drop sets, it takes 60 drops to equal 1 milliliter. Does that make sense?
Yes.
Okay, drip sets come in two primary sizes, a micro drip. This allows for 60 drops, and by the way, the GTT, that stands for drops, okay? 60 drops per milliliter. It has a small needle-like orifice inside the drip chamber. It is ideal for medication administration or pediatric fluid delivery. It is easy to control their flow. A macro drip allows 10 to 15 drops per milliliter. Large opening between the piercing spike and the drip chamber, and is best for rapid fluid replacement. Blood sets are a special type of macro drip set. It's designed to facilitate rapid fluid replacement by manual infusion of multiple IV bags or IV and blood replacement combinations. Most sets have dual piercing spikes that allow 2 bags of fluid to be hung simultaneously for the same patient. Preparing an administration set. To prepare to spike the bag with the administration set, follow the steps in your skill drill 13.1. Choosing an IV site. It's important to select the most appropriate vein for IV catheter insertion. Use the following criteria to select a vein. Locate the vein section with the straightest appearance. Choose a vein that has a firm, round appearance or is springy when palpated, and avoid areas where the vein crosses over joints. That's easy to say, right? They're not, the veins in your patients are not going to look like the man in this picture. Let me just go ahead and bust your little bubble. This is not real life. This is textbook. All right, avoid any extremity that shows signs of trauma, injury, infection, or edema. Avoid any extremity with a dialysis fistula, and avoid any extremity on the same side as a prior mastectomy or lymph node dissection surgery. Pay careful attention to areas of the vein that have track marks, because this is usually a sign of sclerosis caused by frequent puncture or cannulation. If IV therapy is being given for a life-threatening illness or injury, choice is often limited to the areas that remain open during hypoperfusion. For patients who are in critical condition, always start at the antecubital fossa or higher, so at the AC or higher if they're critical. Start distally and work proximally. What does that mean?
At the hand and work up.
Start at the hand and work up. Large protruding arm veins can be deceiving in their ease of cannulation, and that is the truth. Often these bulging veins can move side to side during cannulation, causing you to miss the vein and resulting in possible infiltration. Hold hand veins in place by pulling the skin over the vein taut with the thumb of your free hand as you flex the patient's hand. Stabilize wrist veins by flexing the wrist and pulling the skin taut over the vein. Apply lateral traction to the vein with your free hand. Applying lateral traction to the vein with your free hand can stabilize veins in the forearm and the AC areas. Caution must be used when cannulating leg veins. There's a greater risk of infection or venous thrombosis and subsequent pulmonary embolus. Choosing a catheter. Over-the-needle catheters and butterfly catheters are the most common. Catheter selection should reflect the need for IV administration, the age of the patient, and the location site. Over-the-needle catheters are sized by their diameter, referring to the gauge. Select the largest diameter catheter that will fit the vein you have chosen, or that will be the most appropriate and comfortable for the patient. The more distal the IV site, the smaller the catheter. Over-the-needle catheters can be used for all adults and most children for long-term IV therapy. A contaminated stick occurs when an advanced EMT punctures his or her skin with the same catheter that was used to cannulate the vein of a patient. Newer over-the-needle catheters use several different methods to protect an advanced EMT from the possibility of a contaminated stick. Inserting the IV catheter. Each advanced EMT has a unique technique. Observe many different techniques to determine what works best for you. No matter what technique you use, keep the beveled side of the catheter up when inserting the needle in a vein. Maintain adequate traction on the vein during cannulation. Do y'all all understand what they're talking about when they're saying over-the-needle catheters and bevel side? If there's something that I say in this that you don't quite understand, stop me, okay?
Okay.
Apply a constricting band above the site you have chosen. Do not leave the constricting band applied while you assemble IV equipment. If a commercial device is not available, constricting bands can be made of any available material, such as a Penrose drain, a blood pressure cuff, gloves, surgical tubing. After you have selected an insertion site, prep it with an alcohol swab, iodine swab, or chlorhexidine or a chloroprep. Do not touch the site after it has been prepped. Apply gentle downward or lateral traction on the vein with your free hand while holding the catheter bevel side up in your dominant hands. Advance the catheter through the skin until the vein is pierced, then immediately drop the angle down to approximately 15 degrees and advance the catheter a few more millimeters to ensure that the catheter sheath is in the vein. There may or may not be a flash of blood in the catheter flash chamber when a vein is pierced. Slide the sheath off the needle and into the vein. Do not advance the needle too far because it can lacerate the back wall of the vein. After the catheter is fully advanced, apply pressure to the vein just proximal to the end of the indwelling catheter, remove the needle, and dispose of it in a sharps container. Did all of that make sense to everybody?
Yeah, but I actually don't think I'm gonna get it till I do it.
Yeah. So you're not going to go straight down. You're going to go in at an angle. Once you get flash in that chamber and you know that you're inside, you're going to advance it just a little bit more. Because as you look at the IV needles, the actual needle part comes out just a couple of millimeters more than where the sheath, the clear tube that stays inside the vein, where that starts. So if you stop as soon as you get flash, that sheath may not actually be inside the vein and you're not going to be able to thread it through. Does that make sense?
It does.
So once you pierce, you're going to go just a fraction more to ensure that that sheath is in there, and then you're going to advance the sheath and pull the needle out, okay? All right. Drawing blood. If blood is drawn, it must be drawn before any fluids or medications are administered. Why is that?
So they read right?
Do what?
So like the test they run on it reads correct?
Right, because anything that you push in this vein is going to mix in the blood or dilute the blood, so any lab work's not going to be accurate. Drawing blood is not always possible. If you are having difficulty drawing blood, stop and finish establishing the IV line. A vacutainer connects to a catheter to assist with blood collection. If you do not have a vacutainer set up, you can draw blood from the IV site using a 15 to 20 milliliter syringe. Follow local protocols for the types of blood tubes and draws. Label all the tubes with the patient's name, the date, the time, and your name. So the vacutainer is that little clear round plastic tip that goes on the end of it that you actually stick the blood collection tube in to pull the blood out. I know all of y'all have seen those. Securing the line. Tape the area so that the catheter and tubing are securely anchored in case of a sudden pull on the line. Tear the tape before you start IV administration. That's actually part of your National Registry checkoff for this skill, is that you tear the tape before you start the IV. Double back the tubing to create a loop that will act as a shock absorber if the line gets pulled accidentally. Avoid any circumferential taping around an extremity. Steps in performing IV therapy are summarized in Skill Drill 13.2. Changing an IV bag. Do not allow an IV fluid bag to become completely empty. Change the bag when approximately 25 milliliters of fluid is left. Replacing the IV bag is a sterile process. Steps for changing an IV fluid bag. Stop the flow of fluid from the depleted bag by closing the roller clamp. Prepare the new IV bag by removing the pigtail from the piercing spot port. Inspect the new bag of IV fluid for clarity and discoloration, as well as the expiration date. Remove the piercing spot from the depleted bag and insert it into the port on the new bag. Do not touch the piercing spot of the administration set. Ensure the drip chamber is appropriately filled, and then open the roller clamp and adjust the fluid rate accordingly. How do we fill that drip chamber, and how much do you fill it?
You pinch it before you put it in the bag.
So after you spot the bag, after you put the spot through the bag and the fluid starts dripping out into the chamber, you're going to squeeze it and fill it up about halfway. All right, discontinuing the IV line. To discontinue the IV line, shut off the flow from the line with the roller clamp. Gently peel the tape back towards the IV site. As you get closer to the site and the catheter, stabilize the catheter while you loosen all remaining tape. Do not remove the IV tubing from the hub of the catheter. Fold a 4" by 4" piece of gauze and place it over the site, holding it down while you pull back on the hub of the catheter. Gently pull the catheter and the IV line from the patient's vein while applying pressure to control bleeding. Alternative IV sites and techniques. Some additional IV sites and techniques available to pre-hospital providers require training beyond the scope of this chapter. Saline locks are a way to maintain an active IV site without having to run fluids through the vein. It's used primarily for patients who do not need additional fluids but may need rapid medication delivery. Access ports commonly used with patients who have disorders such as heart failure or pulmonary edema. A saline lock is attached to the end of an IV catheter and filled with approximately 2 milliliters of normal saline. The saline remains in the port without entering the vein, preventing clotting. This is a sealed access site. It's also known as intermittent sites. It eliminates the need to reestablish an IV line each time a patient needs medication or fluid. External jugular IV lines. These provide venous access through the external jugular veins of the neck, the same veins used to assess jugular vein distension. Tamponade the vein by placing a finger or the edge of a tongue depressor on the vein just above the clavicle, causing the vein to fill. If the vein is difficult to find, place the patient supine to facilitate venous return. The catheter is inserted midway between the angle of the jaw and the midclavicular line in the same manner as a normal IV line. Okay? So I want you to notice in this picture what direction they're inserting that in, okay? So when you're starting IVs in the hands and the arms, what direction are you going?
Towards the heart.
Towards the heart.
Towards the heart.
Towards the heart, always towards the heart. So keep that in mind. If you ever do stick an EJ, you're still going to be going towards the heart. So you're going to be going down from the head towards the heart, okay? Troubleshooting IV therapy. Several factors can influence the flow rate of an IV line. Perform these checks after completing IV administration and recheck if there's a flow problem. Check your IV fluid, administration set, the height of your IV bag, the type of catheter used, and your constricting band. Signs and symptoms of infiltration include edema at the catheter site, continued IV flow after occlusion of the vein above the insertion point, or the patient complains of tightness and pain around the IV site. To correct infiltration, discontinue administration and reestablish the IV line in the opposite extremity or at a more proximal location on the same extremity. Apply direct pressure over the swollen area to reduce further swelling or bleeding into the tissue. Avoid wrapping tape around the extremity for direct pressure. Thrombophlebitis is inflammation of the vein. This is not usually seen with the emergency pre-hospital patient. You may encounter it in patients who abuse drugs or are receiving long-term IV therapy. Symptoms include fever, tenderness, and red streaking up the associated vein. Hardening of the vein can occur if a vein has been repeatedly punctured. Common causes include localized irritation infection from non-sterile equipment, prolonged IV therapy, irritating IV solutions, or too rapid infusion. If redness develops at the IV site with rapidly developing thrombophlebitis, discontinue the infusion and save the equipment for later analysis. Reestablish the IV line in the other extremity with all new equipment in case there were unseen contaminants in the old equipment. Document the event and the patient's response. Occlusion, this is physical blockage of a vein or catheter. If the flow rate is not sufficient to keep fluid moving out of the catheter tip, and if the blood enters the catheter, a clot may form and occlude the flow. Decreasing the drip rate or the presence of blood in the IV tubing is the first sign. Common causes include a positional IV site, proximity to a valve, patient movement that allows the line to become physically blocked from either resting on the line or crossing the arms, or the IV bag nears empty and the blood pressure overcomes the flow and backs up the line. What's positional IV site? What does that mean?
Would that be like the catheter bending?
So,
It means like if you bend your arm or you move your hand, it don't work.
yes, so a certain position or the least little bit of movement of that catheter can stop it from flowing. So it may have to be pulled back on a little bit, taped a different way, hold your arm straight, things like that, having to change position to keep that flowing. To determine whether an IV line should be reestablished, use a syringe filled with saline to add pressure to the line. Gently apply pressure to the plunger to disrupt the occlusion and reestablish flow. If flow is reestablished, ensure that the line is free and the rate is sufficient. If the occlusion does not dislodge, discontinue administration and reestablish an IV line in the opposite extremity or at a proximal location on the same extremity. Hematoma is an accumulation of blood in the tissue surrounding an IV site. It results from vein perforation or improper catheter removal that allows blood to accumulate in the surrounding tissues. Blood can be seen rapidly pooling around the IV site, resulting in tenderness and pain. If a hematoma develops while you are attempting to insert a catheter, stop and apply direct pressure to help minimize bleeding. If a hematoma develops after a successful catheter insertion, evaluate the IV flow and the hematoma. If the hematoma appears to be controlled and the flow is not affected, monitor the IV site and leave the line in place. If a hematoma develops as a result of removing the IV line, apply direct pressure with a 4x4 gauze pad to the site. Nerve, tendon, or ligament damage. This results from improper identification of anatomic structures around the IV site. The risk increases with an IV site choice around joints. Symptoms include sudden severe shooting pain, numbness in the extremity. Immediately remove the catheter and select another IV site and document the event. Arterial puncture. Occasionally, cannulation of an artery may occur. Bright red blood is quickly seen either spurting from the catheter after the needle is withdrawn or backing up into the IV tubing and the IV bag. If cannulation of an artery occurs, you must stop IV administration, Apply direct pressure to the site with gauze for at least 15 minutes and certainly until any bleeding is controlled. Systemic complications can develop from reactions or complications associated with IV insertion. This usually involves other body systems. It can be life-threatening. If the IV line is established and patent, do not remove it. It may be needed for treatment of the patient. Allergic reactions are often minor, but anaphylaxis is possible. Any allergic reaction must be treated aggressively. This can be related to an individual's unexpected sensitivity to medication. Such sensitivity could be an unknown condition to the patient. Maintain vigilance with any IV line for a possible reaction. Patient presentation depends on the extent of the reaction. Common signs and symptoms include itching, shortness of breath, edema of the face and hands, urticaria, bronchospasms, anaphylaxis, wheezing. If an allergic reaction occurs, discontinue IV administration and remove the solution. Leave the catheter in place as an emergency medication route. Notify medical control immediately and maintain an open airway. Monitor the patient's ABCs and vital signs, and document the event and keep the IV bag or medication for evaluation by the hospital. Air embolus. Patients who are already ill or injured can be affected if any air is introduced into the IV line. An air embolus is an air bubble that blocks blood flow. Properly flushing an IV line will help eliminate any potential of introducing air into a patient. IV bags are designed to collapse as they empty to help prevent this problem. Be sure to replace empty IV bags with full ones. If your patient begins to experience respiratory distress with unequal breath sounds, consider the possibility of an air embolus. Signs and symptoms include cyanosis, signs and symptoms of shock, loss of consciousness, or respiratory arrest. Treat a patient with a suspected air embolus by placing the patient on his or her left side with the head down. Rapidly transport to the closest and most appropriate facility. Be prepared to assist ventilations if the patient experiences increasing shortness of breath or inadequate tidal volume, and document the event. Catheter shear. This occurs when part of the catheter is pinched against the needle and the needle slices through the catheter, creating a free floating segment. Catheter segment can travel through the circulatory system. Blockage of other vessels may result in a myocardial infarction, stroke, or other problems. This can possibly end up in the pulmonary circulation, causing a pulmonary embolus. Treatment involves surgical removal of the sheared tip. Catheter hubs are radioplaque to aid in diagnosing this type of problem. Never rethread a catheter. Patients who have experienced catheter shear with pulmonary artery occlusion may present with sudden dyspnea, shortness of breath, and possibly diminished breath sounds. Treat the same way as a patient with an air embolus. Try to obtain an IV line in another extremity. So, when it talks about rethreading a catheter, when a lot of people, when they get flash, but it might just be a little bit, it may not be just a continuous flow and fill that whole chamber up on that needle, so they don't know that they're in there. They might pull the needle out a little bit to see if there's blood filling up in the catheter. And also, when they're pulling it out of the initial pack that it comes in, it has the cap on it. Sometimes when you pop that cap, it might pull the shear off a little bit, the sheath off a little bit. So, with that being said, it's talking about rethreading the catheter. So when you do that, when you push the needle back through the catheter, a lot of times the tip of that bevel is very, very sharp. it might hit that plastic and just take a little piece of it off. Or it might slice it enough that once you push it through the skin and into the vein, it could shear off. So that's what that's talking about when it says never ever re-thread a catheter. Does that make sense?
It does.
Okay, circulatory overload. An unmonitored IV bag can result in circulatory overload. Patients with cardiac, pulmonary, or renal dysfunction cannot tolerate any additional demands from increased circulatory volume. In trauma patients, increased circulatory volume from overaggressive resuscitation can disrupt clot formation and increase ongoing hemorrhage. The most common cause of circulatory overload in the pre-hospital setting is failure to readjust the drip rate after flushing an IV line immediately after insertion. Always monitor IV bags to ensure the proper drip rate. Patient presentation includes dyspnea, jugular vein distension, and increased blood pressure. Crackles are often heard when evaluating breath sounds. To treat a patient with circulatory overload, slow the IV rate to keep the vein open and raise the patient's head to ease respiratory distress. Administer high flow oxygen and monitor vital signs and breathing adequacy and document the event. Vasovagal reactions. Some patients have anxiety concerning needles or the sight of blood. This may cause vasculature dilation, resulting in a decrease in blood pressure and patient collapse. Signs include anxiety, diaphoresis, nausea, and syncopal episodes. Treatment for a patient with a vasovagal reaction centers on treatment for shock. Place the patient in the position dictated by protocol for shock management. Apply high flow oxygen, monitor vital signs, and establish an IV line in case fluid resuscitation is needed. Pediatric IV therapy considerations. The same IV solutions and equipment can be used on pediatric patients as adults with a few exceptions. Catheters, they're available in various sizes. 20, 22, 24, or 26 gauge over the needle catheters are best for insertion, depending on the size of the patient and the size of available veins. Butterfly catheters are ideal for pediatric patients. Scalp veins are best used in young infants. I know none of you are looking forward to putting a needle in a baby's head. IV locations. Explain the process to the child and parents. The younger the pediatric patient, the fewer choices you have for IV sites. Hand veins are painful but remain the location of choice for starting peripheral IV lines. Protecting the IV site after it has been established is critical. One of the better techniques for starting pediatric IV lines is to use a pen light to eliminate veins on the back of the hand. Be sure not to burn the patient with the pen light. Scalp vein cannulation is often aesthetically unpleasant for both the child and the parents. When you are securing a scalp vein, tape a paper cup over the site to avoid applying any direct pressure to the butterfly catheter. Geriatric IV therapy considerations. Smaller catheters may be preferable unless rapid fluid replacement is needed. Some medications used by older adults have the tendency to create fragile skin and veins. Often, simply puncturing the vein will cause a massive hematoma. The use of tape can result in skin damage. Catheters, try using smaller catheters, 20, 22, or 24 gauge. IV sets, be careful when using macro drips. They may lead to edema if not monitored closely. Fluid overloading is potentially serious in geriatric and pediatric patients, so monitor fluid administration carefully. Y'all still with me?
Yeah.
Okay. Locations. In choosing an IV site, consider the possibility of poor vein elasticity. Aging causes loss of elasticity in the body tissues. Avoid small spidery veins that weave back and forth. Do not use varicose veins as they allow very little circulation. Somebody somewhere has done that, or they wouldn't put it in your book, I promise. Intraosseous infusion. Intraosseous means within the bone. Intraosseous infusions is a technique of administering fluids, blood, and blood products and medications into the intraosseous space of the proximal tibia, the humeral head, or the sternum. Long bones consist of a shaft or diaphysis, the ends, the epiphyses, and the growth plate, the epiphyseal plate. The IO space comprises the spongy cancellous bone of the epiphyses and the medullary cavity of the diaphysis. The IO space is commonly referred to as a non-collapsible vein. Anything that can be given via the IV route can be given via the IO route. IO infusion is indicated when you are unable to rapidly obtain IV access in a critically ill or injured patient. Vascular access times and flow rates for various IO sites are presented in Table 13.2 of your book. IO sites, the sternum, humerus, and proximal tibia and distal tibia are the common sites. The technique for performing IO infusion requires proper anatomic landmark identification. To locate the humeral IO site, you will need to manipulate the patient's arm and palpate the humeral head. Identify the sternal IO site by palpating the sternal notch and using the IO device's adhesive target. The sternal site has an extremely rapid flow rate. To locate the proximal tibia IO site, palpate the tibial tuberosity, then palpate 2 centimeters medially. For the distal tibia IO site, identify the medial malleolus, then palpate 2 to 3 centimeters above it. And guys, I know this is going kind of fast, so don't freak out thinking I have no idea where to put this stuff. Read your book, memorize it, but we are going to do this stuff hands-on in class during lab, okay?
All right.
Equipment for IO infusion. Several products are used for placing an IO needle into the IO space. Manually inserted IO needles. Fast 1, Easy IO, bone injection gun, BIG, and new intraosseous NIO device. Y'all, the bone injection gun, they sent us these way back when, Gates Snowball days, and me and John Ho actually, we wanted to see like how good they were, and we wanted to play with it before we tried to use it on a patient. And we went in the supply closet and found a stud and like did a nail on the stud of the wall, and that thing was like a freaking nail gun going off. Like I would never, I would never want to use that on a patient. Yeah, and we couldn't get it out of the wood either. It was awful. So I'd hate to see what it did to a bone. But yeah, we use on the truck the manuals, that the blue one in the picture there. If you haven't seen them on the truck, it's in the picture there. Um, and then easy IOs and the drills, those are good ones too. Use of these devices requires specialized training and thorough familiarity. I've had problems with that word all night. With their features, functionality, and clinical application. They consist of a solid boring needle, trocar, inserted through a sharpened hollow needle. The IO needle is pushed into the bone with a screwing, twisting action. After the needle pops through the bone, the solid needle is removed and the IV tubing is attached to the catheter. It requires full, careful immobilization. Stabilization is critical for these lines to maintain adequate flow. FAST devices. First IO devices approved for use in patients aged 12 years and older. There are 4 design elements that allow the IO placement in the sternum using a FAST device. It's an infusion tube and subcutaneous portal, an introducer, a target strain relief patch, and a protective dome. This can be used during cardiac arrest. The company that developed the FAST devices chose sternum placement based on the ease of locating the manubrium. The FAST one consists of a 14 gauge infusion tube and 10 stabilization needles. The Fast Responder, or FAST-R, is an updated device that has some advantages. To remove either FAST device, firmly grasp the insertion tube and pull steadily until the device is dislodged. Use one continuous motion for removal and avoid starting and stopping. Easy IO features a handheld battery-powered driver to which a special IO needle is attached. This is used to insert an IO needle into the proximal or distal tibia of adults and children and the humeral head in adults. It is battery-powered driver of the Easy IO is universal. Different sizes of needles are available depending on the patient. Table 13.3 lists Easy IO needle sizes and determination criteria. When sizing the needle, you should ensure at least one hash mark 5 millimeters can be seen after insertion. Use a 10 milliliter syringe to remove an Easy IO. Attach the syringe to the IO's lower lock. Twist the syringe clockwise and pull the device out in one swift motion. Yes.
What is it talking about a hash mark?
On the needle, the Easy IO needles have a hash mark on them. So, yeah, so when you're measuring the needle to see like which size that you would need to go into the patient's bone, and the way you measure those is to make sure you have at least one hash mark, which is like 5 millimeters, that you can see that above the skin after you insert it.
Okay, thank you.
That's only on the Easy IOs. Like that's not a standard thing.
Okay.
Bone injection gun, big. That's the one they use to shoot the stud in the closet. Is a spring-loaded device used to insert an IO needle into the proximal tibia of an adult or pediatric patient. It comes in adult size and a pediatric size. The depth of insertion is different for adult and pediatric devices. It uses the safety lock as a stabilization device after the device has been inserted. Use the stabilization device as the removal tool. Once the device, pull the device out in one swift motion while grasping onto the removal tool. New intraosseous or NIO device placed in the proximal tibia of an adult patient. The humeral head is an alternative site for this device. It is spring-loaded with neither drill nor battery, inserted by unlocking a safety cap. While applying downward pressure with the dominant hand, the fingers of the other hand are used to pull the trigger wings up to deploy the device. The device is pulled up in a rotating motion while the needle stabilizer is held against the skin. After the introducing trocar is removed, any lower lock tubing can be attached. A pediatric version is an NOI pediatric or NIOP, and it has an adjustable dial. Performing IO infusion. Follow the steps in Skill Drill 13.3 to perform IO infusion using an easy IO device. To attach a fast one device, follow these steps. Align the adhesive target on the patient and prepare to insert the device into the manubrium. Prepare the insertion site on the patient's manubrium. Position yourself behind the patient's head. Place 2 hands on the fast one device. Align the stabilization needles with the target and apply pressure until you feel the infusion tube separate from the fast one introducer. Discard the stabilization needle in a sharps container and attach the IV tubing to the insertion tube's lower lock. Aspirate blood and particles of bone marrow to ensure proper placement. What does it mean to aspirate?
You mean like aspirate as inhaling something in your your lungs, like it goes into your lungs instead of your other part? Are you talking about aspirate as in
on the
aspirating
in the needle?
Yeah.
So when you aspirate blood and particles of bone marrow to ensure proper placement, you're going to pull back on the syringe that's attached to the tubing, and you're going to see the bone marrow or blood fill up the extension set. That's how you know that you're in. Okay. So you'll either see blood or you'll see yellow marrow. Slowly inject the IV solution to ensure proper placement of the needle. Adjust the flow rate as appropriate. Place the protective dome and begin using the device. Potential complications of IO infusion. If used properly, IO infusion is associated with a relatively low complication rate. Potential complications associated with IV therapy can occur with IO infusion. Extravasation occurs when the IO needle does not rest in the IO space. IV fluid will collect in the soft tissues. The risk of extravasation can be reduced substantially by using the proper insertion technique. Insert the IO needle at a 90-degree angle to the bone. Extravasation should be suspected if the infusion does not run freely or if the site rapidly becomes edematous. Undetected extravasation could result in compartment syndrome. Osteomyelitis is inflammation of the bone and muscle caused by an infection.
Look, I was trying to be funny and you didn't laugh. Like everybody's being so serious. I was trying to be funny and you didn't even laugh at me.
Well, it's because I'm being drained by the non-responsiveness tonight that I really didn't get that you were being funny. I was like, okay, B's not paying attention to me at all because she's talking about breathing in.
No, I was trying to be funny because you said aspirate. Do we know what aspiration is? So
Yeah.
I'm like, you're talking about aspirating in the lungs, or you talking about aspiration with the needle?
I
So I was
appreciate
trying to
you.
be funny because it's like dead. Like,
It really
when I
is
say
dead.
but it's dead.
Like, IO stuff is exciting. This is like really exciting stuff. Like to put a needle in a bone and to aspirate marrow, and that's a big deal. That's exciting stuff. And everybody's just kind of like, I don't know if they're scared, if they're trying to be respectful. I don't know. That's why I had to ask for y'all
I'm
here.
not scared. I think it's cool. I mean, because I actually got to do it when I was taking medic before I had to drop out because of my ITP, and it's really cool. But I was trying to be funny. I'm sorry. I was trying to get some humor in here.
I really appreciate you. I really do.
Thank you. Thank you. Thank you very much.
You're welcome very much. So I guess me and you're going to here.
I thought it was funny. I just had my mic turned off.
Okay.
Okay. Can you guys hear me?
I can hear you now.
I can now.
Oh, sorry. I'm here.
Hi. Nice of you to join us.
Hi.
I've been here the whole time.
You've been here the whole time?
The whole time.
Would you like to
she's
sing
been
us?
here.
I know she has. I've been picking on her. Would you like to sing a Sakuna Matata to just kind of bump things up, make it lively?
I'll get my.
I vote yes. I vote yes.
I
You
can't.
have to turn your camera on.
I don't have my. Huh?
I said you have to turn your camera on and sing it for us.
My camera is on. It's not.
No, it ain't.
I swear.
I can sing Maddie.
Say thank you.
Okay, Maddie.
Mine just has an M.
But I don't have my singing partner for Hakuna Matata.
Well, I mean, it'll be fine. You can just sing your part.
But I gotta have Doodle for the rest of the parts.
Okay.
Your day.
Philosophy.
Hakuna Matata.
Okay. So this is the second lecture I have recorded with Maddie singing Hakuna Matata.
I forgot you were recording. You tricked me.
I did trick you, and you fell for it. Like a champ. Like a champ. I love it.
Man.
Yep. Okay, so failure to identify the proper anatomic landmark can result in long-term bone growth abnormalities in children. Remember we talked about before when we were going through the actual human body, and we talked about doing eyes, and if you go through that growth plate in the bones, if you fracture that, those bones may not ever grow again. So that's why it's saying it can result in long-term bone growth abnormalities in children. Fractures can occur if your insertion technique is too forceful or you use an IO needle that is too large for the patient's age or size. Through and through insertion occurs when the IO needle passes through both sides of the bone. Stop inserting the needle when you feel a pop. If you feel a pop, you have likely passed the needle through both sides of the bone. Okay? Suspect a pulmonary embolism if the patient experiences acute shortness of breath, pleuritic chest pain, and cyanosis. What is pleuritic chest pain?
I'm not sure. Chest pain and I don't know.
What are we talking about when we say pleura?
We talk about what?
When we say pleura, what are we talking about?
Pleuritic chest pain? Isn't that like when you get pleurisy?
So anything involving the lungs. So if they say it hurts when they take a deep breath, that's pleuritic chest pain. So it's pain that they feel in the chest, but it's involving the lungs, okay?
Okay.
Okay. Contraindications to
Good job, Maddie.
Very good job, Maddie. Contraindications to IO infusion. If a functional IV line is available, IO cannulation is not indicated. Contraindications to IO cannulation and infusion include fracture of the bone intended for IO cannulation, osteoporosis, osteogenesis imperfecta, bilateral knee replacements, prosthetic limb at the IO sites. All right. You can't do an IO if they're amputee there. Mathematical principles used in pharmacology. I know that y'all are so excited about this section. You will need an understanding of some basic mathematical principles to calculate accurate medication dosages. A mathematic review. Understanding fractions is important in formula calculation. Fractions are expressed as a numerator, a portion available, over a denominator, which is the total quantity. Decimals distinguish numbers that are greater than 0 from numbers that are smaller than 0. Whole numbers appear to the left side of the decimal point and fractions of numbers on the right. Fractions can be easily converted to decimals by dividing the numerator by the denominator. Example, 1/2 of 1 milligram. 1 is divided by 2 and is equal to 0.5. Dividing or multiplying by 10 is simple when you remember the following method. If you are dividing a number by 10, move the decimal point to the left. If you are multiplying a number by 10, move the decimal point to the right. Example, 20 times 10. Place the decimal point 20.0. To multiply by 10, move the decimal point one space to the right for 200.0. Percentages are a part of 100 and are denoted by the percent symbol. It can be represented as a fraction with the denominator 100. Decimals can also be turned into percentages easily by moving the decimal point 2 places to the right. The metric system, decimal system based on multiples of 10. It is used to measure length, volume, and weights. Meter, or M, is the basic unit of length. A liter, a capital L, is the basic unit of volume, and the gram, little g, is the basic unit of weight. Prefixes demonstrate the fraction of the base being used. Commonly used prefixes from smallest to largest include the following. Micro is 0.000001. Milli is 0.001, centi is 0.01, and kilo is 1,000. Table 13.4 illustrates the symbols of weight and volume used in the metric system, and Table 13.5 illustrates the metric units of weight and volume and their equivalents. I highly suggest that y'all know those. You must be able to convert larger units of volumes and weights to smaller ones and vice versa. Volume and weight of the medication can be administered or to be administered may be only a fraction of the total amount. The desired dose refers to the amount of a medication that the physician orders or protocol dictates. Volume conversion. In the pre-hospital setting, you will usually be dealing with milliliters and liters. 1 liter equals 1,000 milliliters. When you are converting milliliters to liters, divide the smaller unit of volume by 1,000. So 100 milliliters divided by 1,000 equals 0.1 liters. When you're converting liters to milliliters, multiply the amount in liters by 1,000. 1.5 liters times 1,000 equals 1,500 milliliters. Weight conversion. To convert grams to milligrams, multiply the larger unit of weight by 1,000. To convert milligrams to grams, divide by 1,000. Converting pounds to kilograms. There are two formulas that can be used to convert pounds to kilograms. Divide the patient's weight in pounds by 2.2. 1 kilogram equals 2.2 pounds. Or divide the patient's weight in pounds by 2 and subtract 10%. Calculating drip rates. When you administer IV fluid, you will need to calculate the drip rate. One of the easiest ways to calculate drip rates is to use dimensional analysis. Dimensional analysis allows you to compare seemingly unrelated items by setting up a relationship and using ratios as conversion factors. To calculate a drip rate, you need to know which administration set to use, the length of time for the infusion, and the amount to flow. Remember that 1 hour equals 60 minutes. Example, order is given for 250 milliliters of normal saline over 90 minutes. The administration set is 5 microdrip or 10 drops per milliliter. Or that's what you're using as a 10 drop per milliliter. To determine how many drops per minute should be given, y'all see that? Do you see all those letters? So that's your homework. That is your equation, and whoever can figure it out first. I'm kidding. So you cancel out what you can with the milliliters and reduce the fractions, and then you multiply and divide that. Yeah, that. So we will have a better example of that for you. Calculating medication dosages. There are multiple formulas for calculating medication doses. The method of drug dose calculation demonstrated here is based on the following three factors: the desired dose, concentration of the medication available, which is the dose on hand, and the volume to be administered. The desired dose is the amount of medication the physician orders you to administer to a patient. It may be expressed as a specific number of grams or milligrams per kilogram of body weight. The medication concentration is the total weight of the medication contained in a specific volume. Note that medications are contained in different volumes of solution. This is your volume on hand. To administer a medication, you must know the weight of the patient that is present. The weight of the medication that is present in 1 milliliter. The weight per millimeter equals the total weight of medication divided by the total volume in millimeters. So an example is a drug order is for dextrose, 25 grams in 50 milliliters. So 25 grams divided by 50 milliliters equals 0.5 grams per milliliter. Does everybody understand that?
I do.
Okay, so if you're ordered to give 12 grams, how many milliliters is that going to be?
I'm thinking. So you said it was 0.5 milligrams, right?
0.5 grams. Yeah, 0.5 grams per milliliter. And you've been ordered
Per
to give,
milliliter.
and you've been ordered to give 12 grams. How many?
24.
24. Very good.
Right?
Yes, absolutely. Who else is here? Kim?
No, Kim's not here. Daniel and Madison's here.
Daniel and Maddie. Maddie.
Yes.
Okay, so you've got 0.5 grams of D50 per milliliter, and you've been ordered to give 10 grams. How many milliliters?
Can you talk me through this? I'm not good at math, and it's gonna make my brain hurt.
So if you have 0.5 grams per milliliter, okay, your drug comes in at, can you see on my notes, the very bottom right here, where it says 25 grams in a 50 milliliter vial. So your vial has 50 milliliters in it, and there's 25 grams total in that 50 milliliters. So to figure out how much is per milliliter, how many grams are per milliliter, you're going to divide the dose by the total amount of fluid. So you got 25 grams divided by 50 milliliters. That gives you 0.5 grams per milliliter. Okay?
Okay.
So if you're ordered to give 10 grams, you've got to be able to figure out how many milliliters that is. So if there is 1/2 a gram per milliliter, then you're going to have 2 milliliters for 1 gram. You with me so far?
Yes.
So if you're given 10 grams, that's going to be 20 milliliters.
20? Okay.
20. Yes. Daniel.
He's sleeping.
He probably is sleeping.
He really is. His face is trying the camera first.
Wow. Okay. So, all right. Does everybody understand that?
I do. Maddie does. We're good.
We're good. Okay.
You're just talking to me and Maddie now. That's it.
Okay.
And Megan's there. Megan's listening.
Yeah, but Megan's an instructor. She's not a teacher. I mean, a student.
She's an instructor, not a teacher. Oh.
One of these things is not like the other. One of these things just doesn't belong. Okay. So volume to be administered. The volume to be administered equals the desired dose, milligrams.
So now it's just me.
Okay,
You
mighty.
got all my attention.
All your attention's on me. Okay. So the volume to be administered equals the desired dose or milligrams divided by concentration on hand, which is milligrams per milliliter. Ensure the units in the desired dose match the units in the top of the concentration on hand fraction. Example, you are ordered to administer 12.5 grams of dextrose to a hypoglycemic patient. You have a pre-filled syringe containing 25 grams of D50 and 50 milliliters. How many milliliters of dextrose will you give? Step 1 is determine the concentration and dose on hand in grams/milliliters. So you have 25 grams divided by 50 milliliters equals 0.5 grams per milliliter. That's your dose on hand. Determine how much volume to administer. 12.5 grams is your desired dose divided by 0.5 grams per milliliter, which is your dose on hand, and that's going to equal 25 milliliters. You will need to administer 25 milliliters or half of the 50 milliliter syringe. Weight-based medication dosages. Some medication doses are based on the patient's weight in kilograms. Remember that 1 kilogram equals 2.2 pounds. Medications you may administer whose orders may be weight-based include pediatric dosages for dextrose, epinephrine, and naloxone. Pediatric doses. Many rescuers use length-based resuscitation tapes. You may carry a field guide with tables or charts for reference. The calculations for pediatric drug dosing and medication infusions are the same as for adults, but the doses and volumes are smaller. Steps for administering by specific routes. Administering enteral medications. These are given through some point or some portion of the digestive or intestinal tract. It includes medications that are administered orally, through a feeding tube, or rectally. Oral administration. Forms of solid and liquid oral medications include capsules, time-release capsules, lozenges, pills, tablets, elixirs, emulsions, suspensions, and syrups. These are used when the desired effect is systemic and the medications are taken up by the intestines. To give oral medications, you may use a small medicine cup, a medicine dropper, teaspoon, oral syringe, or a nipple. Not yours. Medication.
Why not?
I hate everybody else missed that. That was great. Okay.
Don't worry, it's recorded.
Right. And why not? I think that it probably just wouldn't be ethical. Some people might not appreciate that.
Yeah.
Medications administered by advanced EMTs using the oral route include aspirin and oral glucose. All right, follow these steps when administering an oral medication. Take standard precautions. Determine the need for the medication based on patient presentation and obtain a history including any drug allergies. Follow standing orders or contact medical control for permission. Check the medication to be sure it is the right medication and not cloudy or discolored, and that its expiration date has not passed. Check the 10 rights of medical administration. Determine the appropriate dose. If administering a pill or tablet, instruct the patient to swallow the medication with water. Monitor the patient's condition and document the medication given, the route, the time of administration, and patient response. This one's fun. Rectal administration. Some advanced EMTs may be allowed to administer D50. The route of administration,
Not. No, no, no.
no, that's a negative.
I gotta give it to you this way. Sorry about it.
Yeah, it's going to hurt you more than it's going to hurt me. The route of administration depends on
And it
local
might be
protocol.
fun.
I mean, you're wanting to give syrups on your nipple, so it's going to be all right. If rectal administration of D50 is allowed, it should only be used as a last resort when a patient is hypoglycemic. No other route is an option. IV access cannot be established. Check for indications, contraindications, and precautions before giving D50 rectally. Do we need to go over the diagram, Maddie? Or are you good?
I'm good. I'm good. I think I can figure it out.
Okay. Okay, follow these steps to administer a drug rectally. Take special standard precautions. Determine the need for the medication based on patient presentation. Obtain a history, including any drug allergies. Follow standing orders or contact medical control for permission. Determine the appropriate dose and check that the medication is the right medication. There is no cloudiness or discoloration, and the expiration date is not passed. When inserting a suppository, use a water-soluble gel for lubrication. For medications that are in liquid form, some modifications are needed. You may use a nasopharyngeal airway or a small endotracheal tube as your delivery route. Lubricate the end of the nasal airway or endotracheal tube with a water-soluble gel and gently insert it approximately 1 to 1.5 inches into the rectum. Instruct the patient to relax and not bear down. With a needleless syringe, gently push the medication through the tube. Once the medication has been delivered, remove and dispose of the tube. Monitor the patient's condition and document the medication given, route, time of administration, and patient response. Administer.
Get to tell them before you do it, I'm about to put drugs in your booty hole.
Yes, I mean that falls under the right patient education.
Perfect.
Yes. Administering parenteral medications given through any route other than the GI tract. Parenteral routes used by the advanced EMT include subcutaneous, IM, IV bolus, IO, sublingual, transcutaneous, transdermal, and inhalation. IV administration is the most common parenteral drug route used in the pre-hospital setting. Generally, it is the quickest route for getting medication into the central circulation. Equipment, a variety of needles and syringes are used for administering parenteral medications. Most syringes come pre-packaged in color-coded packs with a needle already attached. Needles and syringes may also be packed separately. Choose the appropriate size of syringe and appropriate needle length for the desired route. Syringes consist of a plunger, body or barrel, a flange, and a tip. Most syringes are marked with 10 calibrations per milliliter on one side of the barrel. The 3 milliliter syringe is the most commonly used for injections. Needle lengths vary from 3/8 of an inch to 2 inches for standard injections. Packaging. Parenteral medications are most commonly packaged in ampules, vials, and pre-filled syringes. Ampules are breakable, sterile glass containers that are designed to carry a single dose of medication. Vials may contain single or multiple doses. They have a rubber stopper top and are made of glass or plastic. Many drugs used in the pre-hospital care are carried in vials. A pre-filled syringe is designed for ease of use. Also, single-dose disposable cartridges that use a reusable syringe. Drug reconstitution, injecting sterile water from one vial into a vial that contains powdered medication, making a solution for injection. Ampules, naloxone is an example. When drawing a medication from an ampule, follow the steps in Skill Drill 13.4. Vials. Determine how much of the medication you will need and how many doses are in the vial. For a single-use vial, you will draw up the entire amount in the vial. For a multiple-dose vial, you should draw out only the amount needed. When drawing medications from a vial, follow the steps in Skill Drill 13.5. Remember that after you remove the cover of a vial, it is no longer sterile. If you need a second dose, the top of the vial should be cleansed with alcohol before withdrawing the medication. Some medications that are stored in vials need to be reconstituted. Many come in two separate vials. They may come in two separate vials or in a single vial divided into two compartments by a rubber stopper. To reconstitute a medication contained in an active vial, squeeze the two vials together. Shake vigorously to mix the contents before drawing out the medication. A pre-filled syringe. This comes in a tamper-proof box. It is separated into the glass medication cartridge and a syringe. To assemble the two-part pre-filled syringe, pop the yellow caps off of the syringe and the medication cartridge. Insert the drug cartridge into the barrel of the syringe and screw them together. Subcutaneous administration. It is given into loose connective tissues between the dermis and the muscle layer. Volumes of a drug administered subcutaneously are usually 1 milliliter or less. The injection is performed using a 24 to 26 gauge 1/2 inch to 1 inch needle. Common sites include the upper part of the arms, the anterior part of the thighs, or the abdomen. Patients who take insulin injections usually vary the sites to multiple injections. When you are preparing to administer fluid or medication, you will need to use the aseptic technique, the method of cleansing used to prevent contamination of the site when performing an invasive procedure. This may be accomplished through the use of sterilization of equipment used, antiseptics, and disinfectants. Follow the steps in Skill Drill 13.6 to administer a medication via the subcutaneous route. Intramuscular or IM administration. IM injections are made by penetrating a needle through the dermis and subcutaneous tissue into the muscle layer. It allows administration of a larger volume of medication than the subcutaneous route. There is potential for damage to nerves because of the depth of the injection. Common anatomic sites for IM injections for adults and children include the following: the deltoid muscle, which is in the upper arm, the vastus lateralis is the lateral thigh, and the rectus femoris is the anterior thigh, and the gluteal area is the buttocks. Follow the steps in Skill Drill 13.7 to administer an IM injection. Patients may have their own auto-injector for certain medications, such as epinephrine. Sublingual administration. Sublingual and buccal medications enter the circulatory system much faster than those that travel through the enteral route. There is a vast network of vessels under the tongue, sublingual, and in the cheek for buccal. In order to work effectively, mucous membranes must be moist. Medications may be taken up in the proximal part of the GI tract without reaching the intestines. Medications given by the sublingual route come in tablet, liquid, and spray forms. To administer a sublingual medication, follow the steps in Skill Drill 13.8. Oral glucose is an example of an advanced AEMT medication administered via the buccal route. Intranasal administration is within the nose. It includes nasal spray for congestion or solutions to moisten the nasal mucosa. It is rapidly absorbed, providing a more rapid onset of action than IM injections. Administration is performed with a mucosal atomizer device. The device attaches to a syringe and allows you to spray select medications into the nasal mucosa. Only a few emergency medications can be given intranasally, and this includes naloxone, Follow local protocols or consult with medical control about the appropriate doses. To administer a medication via the intranasal route, follow the steps in Skill Drill 13.9. Medications administered by the inhalation route. This is used for many medications that treat respiratory emergencies. The most common is oxygen. Check your drug reference guide or the package insert for indications, contraindications, and precautions before giving any medications. A patient with a history of respiratory problems will usually have a metered dose inhaler to use on a regular basis or as needed. Medications administered by the MDI can be delivered through a mouthpiece held by the patient or by a mask for young children and patients who are unable to hold the mouthpiece. Follow steps in Skill Drill 13.10 to help a patient self-administer medication from an inhaler. For more severe problems, liquid bronchodilators may be aerosolized in a nebulizer for inhalation. Small volume nebulizers are the most commonly used method of administration of inhaled medications in the pre-hospital setting. Some adapters have been designed to allow providers to administer nebulized medications to intubated patients. Follow the steps in Skill Drill 13.11 to administer a medication via a small volume nebulizer. Some patients will not be able to effectively inhale beta agonist medications into the lungs via a nebulizer or a metered dose inhaler. In this case, use a small volume nebulizer in line with the assistive device. When utilizing CPAP, most manufacturers have a nebulizer that is designed to work with their device. Intravenous medication administration places the drug directly into the circulatory system. It is the fastest route of medication administration for advanced EMTs to administer. It bypasses most barriers to drug absorption. There is no room for error. Medications are administered by direct injection with a needle and syringe into an established peripheral IV line. Many services now use needleless systems to provide protection against needle sticks. The syringe simply screws into the injection port. A bolus is a single dose given by the IV route. It can be small or large quantity of a drug. Some medications require an initial bolus and then a continuous IV infusion to maintain a therapeutic level of the drug. Complications may arise from using the IV route, including local and systemic. Follow the steps in Skill Drill 13.12 when administering a medication via the IV bolus route. Follow these steps to administer a medication through a saline lock or intermittent site. Take standard precautions. Determine the need for the medication based on patient presentation. Obtain a history, including any medication allergies and vital signs. Follow standing orders or contact medical control for permission. Check the 10 rights of medication administration. Explain the procedure to the patient and the need for the medication. Assemble needed equipment and draw up the medication. Cleanse the injection port with alcohol or remove the protective cap if using the needleless system. Insert the needle into the port while holding it carefully or screw the syringe onto the port. Pull back slightly on the syringe plunger and observe for blood return. Place the needle and syringe into the sharps container. Clean the port and insert the needle with the syringe containing the flush. Flush the saline lock and place the needle in the sharps container. Store any unused medication properly. Monitor the patient's condition and document the medication given, route, time of administration, and patient response. Intraosseous medication administration is used for critically ill or injured children and adults when IV access is difficult or impossible to obtain. Any fluid or medication that may be given through an IV line can be given by the IO route. It is necessary to use a large syringe to infuse the fluid. A pressure infuser device should be used when infusing fluids in adults. Potential for compartment syndrome if fluid leaks outside the bone and into the osteofascial compartment. Follow the steps in skill drill 1313 to administer a medication via the IO route. Okay, that's it for chapter 13. There will be a bonus on this test, but you got to text me to get the bonus information. If you can hear me over Grundy's radio, I will say it again. So there will be a bonus on this test, but you have to text me to get the answer for the bonus.